Thank you, Dr. Pulst. There are many Japanese members of the American Academy of Neurology, and the Academy has worked closely with Japanese neurology in organizing attendance for this meeting. And as your president, I will open the Japanese Society of Neurology meeting in May. Our close ties with Japanese friends has made the devastating earthquake and the monstrous tsunami of tremendous concern to all of us. 30,000 deaths and millions of personal tragedies. Their tragedies affect us all deeply. The Academy has made a donation to the Red Cross to help with recovery in Japan. I would like to invite you to stand, please, and join me in a moment of silence, honoring and remembering our Japanese colleagues and the heroism of the Japanese people in the face of adversity. Thank you. It is an enormous pleasure to be able to give my 2011 President's Award to Dr. James Burnett. Jim is a towering figure in neurology nationally and internationally because of his preeminent position in ethical issues in neurology specifically and medicine more broadly. He is a triple threat neurologist, teacher, clinician, academician who has served the American Academy of Neurology in too many ways to list: multiple committees, its board of directors, and many of its teaching programs. Jim has been an admired colleague, great friend, generous collaborator, and trusted advisor. Dr. Jim Burnett.
I'm honored and humbled to receive this recognition. It's been my privilege to serve the Academy. Birch, thank you very much.
I would now like to honor two special groups of American Academy of Neurology members. Fellowship in the Academy, FAAN, recognizes our Academy leaders and the Academy leaders in neurology worldwide. Leaders in practice, teaching, research, and service, and involvement in the Academy. I want to recognize our new fellows, many of whom I know personally. Would our new fellows please rise? Please join me in congratulating them. Next, I want to recognize our distinguished 50-year members. They have been members since the earliest days of the Academy. please join me in congratulating our 50-year members. I've been interested in finding new treatments for neurological diseases for my entire career. And I've been equally interested in recruiting neurologists to pursue training for a career in experimental therapeutics. This morning, I want to consider with you how we've done so far in developing treatments and some of the challenges confronting us, looking at the prospects for meeting the challenges, and then reflecting with you concerning what our opportunities and responsibilities are. I've also been interested in teaching, and I've found two keys to teaching that have shaped my thinking. First, when I have an epiphany, a realization that I was ignorant or wrong about something, I generally find I'm in good company, and many others need the same message. In preparing this talk over the past 2 years, I realized over a year ago that I had not been sufficiently aware of a key aspect of treating patients. Second, I knew but hadn't realized how important it is to teach in the context of what has been termed by oncologists the teachable moment, or riding the crest of the teachable moment. Taking advantage of the time when a patient is first diagnosed to get your messages across to the patient, family, and friends. Translational is an old word, now being used in new and useful ways, but differently by different people. I'll briefly define how I use the term, then I'll consider the report card for 5 specific disease examples before considering some of the challenges facing us in the search for new treatments. And finally, I'll conclude with some recommendations for what we, as neurologists, can and should do. In this talk, I'm going to let my colleagues and trainees tell much of the story. I will also show 2 beginning investigators who trained in experimental therapeutics with me, and then highlight what I feel we should all be attempting. Defining what I mean by each of the 3 phases of translation is essential to make my points. First, T1, translating discovery from the laboratory into mice and on into humans for the first time. This is largely the work of academic neuroscientists, often neurologists. T2, I define as translating basic research into clinical trials of a diagnostic test, a prevention strategy, or a new treatment, phase 2, 3, 4 clinical trials. T2 also looks at cost effectiveness and other aspects of clinical trials. T3, not everyone uses this term, and this is much less familiar territory to neurologists. How do we get our patients to do what they should, take what they should, prevent what they should? How do we change neurologists and referring physician behavior so that they set a high priority on changing the behaviors of patients? I've known this was important, and I've tried to do it, but I never fully appreciated the importance of the science of learning how to do it. Here is the first of 3 report cards. For T1, we're brilliant. We know hundreds of mutated genes. We can make animal models. We can find possible treatments, often small molecules that improve a mouse model. We're not as good yet on gene-modifying treatments, but on the whole, we're confident that we will be able to do it soon. For T2, we're not quite as good, but we have many new treatments, some that are truly breakthroughs, which my friends will tell you about this morning. However, lots of tough questions remain, most beyond the scope of my talk. A big one is dealing with those of which we can afford and which we can't afford, and ultimately, who should receive the expensive new treatments. For T3, I hadn't planned to discuss this. This is the bit I found I hadn't given enough thought to. It is alien territory for most neurologists, including me. But over the past 2 years, I've come to believe I'm wrong and that we must change. Other specialties are ahead of us, some of them way ahead. The very thing that made me interested in neurology, the opportunity for an intuitive clinician to figure out a tough case and then find a treatment for that patient, may be one of the reasons we're bad at this. Not only we, but our funding agency, premier funding agency, the NINDS, haven't yet championed the cause of optimizing and standardizing care. I sometimes worry that when our academy practice guidelines conclude that there's a lack of evidence, we say to ourselves, great, I can continue to do it my way. I haven't abandoned my initial plan to give a progress report on T2, treatments for our diseases, but since one of my speakers tells you that the medical profession, including neurologists, have done a disastrous job of implementing what we know, I want to make sure I get this message across. Now I want to have my friends, the people who helped me when I was editor of Neurology, and your colleagues give you a brief summary of our progress on treatment, where we are now, and where they expect us to be in the near future. First, Dave Knopman on Alzheimer's disease. He talks first about current treatment, and then about the possibility of prevention, and then about the prospects for the future.
I prescribe one of the cholinesterase inhibitors, or memantine, to my patients with symptomatic Alzheimer's disease, but I point out to them and their families that these drugs don't stop the underlying biology of the disease. They're only symptomatic for a relatively short period of time, perhaps 6 or 9 months. Unfortunately, there aren't any preventive approaches to Alzheimer's disease at this time. There's no question that cardiovascular risk factors increase the likelihood of developing Alzheimer's disease later in life, and therefore treatment of cardiovascular risk factors beginning in midlife almost certainly will have a benefit in later life. There are many drugs that are being tested in phase 2 and phase 3 clinical trials at this time. Many of them are based on the amyloid hypothesis. As shown in this slide, though, we now recognize that amyloid accumulation begins decades before people become symptomatic, and therefore treatment of amyloidosis once people become symptomatic may not be the best approach. To prevent Alzheimer's disease, reduction of the burden of amyloid in midlife and early late life is critical. We now have the capability of doing that using amyloid imaging, such as with Pittsburgh Compound B and other developing agents. Once people become symptomatic, however, we're going to have to find new targets that are involved in the neurodegenerative process. I fully believe that we're on the verge of identifying those targets, perhaps directed at the tau protein, and in the future we will have a whole new array of anti-Alzheimer therapies.
So for Alzheimer's disease, we have worthwhile treatment now, and the breakthroughs are within view. Next, Ann Cross on multiple sclerosis, the current successful treatment of attacks, and what's next.
The MS field has seen really exciting changes over the past 15 to 17 years. Now, in a fairly large proportion of patients, we can actually stop the disease early in its tracks with our frontline agents of the beta interferons and glatiramer acetate. Some patients, however, don't respond well to these. And in those less optimally treated patients, we use agents such as natalizumab, a monoclonal antibody. Natalizumab, as you know, has been associated with progressive multifocal leukoencephalopathy in a small percentage of patients who receive it, but it can be quite effective. I believe most people in the MS field reserve this agent for those patients who fail the frontline beta interferons and glatiramer acetate. Now, just recently, we've received FDA approval for an oral immunomodulatory agent, fingolimod. This is very exciting for patients and for physicians, not only because it's oral, but because in a head-to-head 12-month trial against Avonex, fingolimod-treated patients did much better with about a 50% increase in reduction in relapse rate over Avonex. In terms of the future, there are a number of new agents that are currently under study. These include a number of oral agents as well as more monoclonal antibodies directed against very specific parts of the immune system. The oral agents, some of which have actually been used for a number of years in Europe, appear to be overall fairly safe, especially those that are modulatory. Alemtuzumab is already on the market for oncology purposes, and in a head-to-head trial against Rebif a few years ago was more effective. However, this constitutes a very aggressive type of therapy because it's immunosuppressive and has a long duration, as well as being associated in a number of MS patients with the development of new autoimmune disorders when treated with it.
So we've seen wonderful progress in the treatment of MS. And Ann Cross goes on to predict that the next decade will change the classification of MS, will define the genes that predict or protect against MS, and lead to individualized treatment and better ways to monitor treatment. Relapsing MS may be completely preventable, but much more has to be done before we can even understand, let alone prevent, progressive MS. You will hear much more about the future for MS presented by the Wartenberg lecturer Steve Hauser later this morning. Next, focusing on one of the movement disorders, where, as you all know, there's been a truly major breakthrough advance, Roger Albin on Parkinson's disease.
Now, in terms of treatment, the cornerstone of treatment remains dopamine replacement with L-DOPA and adequate amounts of carbidopa. This has really been a revolutionary therapy since it was introduced in the early 1970s, and there are indications that it's actually changed the natural history of Parkinson's disease. I think the best example of that is the fact that today we recognize that it's many of the non-motor, non-dopaminergic features of Parkinson's disease, such as dementia, sleep disorders, postural problems, and psychiatric problems, which are really the most disabling features of Parkinson's disease. In terms of other treatments, in terms of the available pharmacology, we have really other agents which are largely adjunctive to the treatment of L-DOPA. Dopamine agonists, the COMT inhibitors, the MOB inhibitors, these are drugs which really, I think, are best used largely in conjunction with L-DOPA. Some of them work primarily by boosting the efficacy or changing the pharmacokinetics of L-DOPA. The dopamine agonists are a substitute for L-DOPA, but clearly are not as effective and tend to have much more in the way of side effects than L-DOPA treatment. The other notable therapeutic improvement we've had in the last couple of decades has been the development of deep brain stimulation. So this is a very effective therapy for carefully selected patients. It's targeted at physiological abnormalities that occur in the basal ganglia downstream from the dopamine depletion in the striatum. And like all surgical therapies, patient selection is the key to getting good results. But in quite a few patients, there's a significant improvement in motor function. There's often a significant reduction in medication dosing, which results in less side effects. It has the risks of a surgical procedure and also some risks, additional risks, which of cognitive or behavioral problems associated with deep brain stimulation.
So we have major progress in treating the motor signs and symptoms, but now Roger Albin will consider approaches that will to the still unsolved problem of treating the non-motor manifestations of Parkinson's disease. Note that he mentions the amazing work of neuroscientist Carl Dieseroth, who will be speaking in 2 days at this meeting in Thursday's plenary session.
Looking ahead to the future, I think important areas of research are understanding the multisystem nature of the pathology in Parkinson's disease better. I think if we are able to correlate some of the specific deficits in different brain pathways with different clinical features of Parkinson's disease, we have real potential to develop substantially better symptomatic treatment of Parkinson's disease patients. I think another very exciting area which comes from the basic science literature is the application of optogenetic methods, which is a toolkit of physiological methods which allow very specific manipulation of neuronal populations in behaving animals. I think these particular methods have the potential to allow us to have a real physiological understanding of what these brain circuits do and what the real physiological abnormalities are in those brain circuits in diseases like Parkinson's disease. And that would allow us to design therapies much more rationally.
Next, Jackie French gives her perspective on epilepsy, where we've made wonderful progress with many drugs and 3 specific treatments for specific forms of epilepsy, as well as surgical approaches.
We've made enormous progress with drugs. We now have 17 anti-epileptic drugs to treat with, and this will allow us to render 2/3 of our patients seizure-free, and only 1/3 have continued seizures. In addition, we have very targeted populations, such as, for example, patients with infantile spasms who have tuberous sclerosis who respond very specifically to vigabatrin. We have absence epilepsy that responds very specifically to ethosuximide, and we have the primary generalized epilepsies, such as juvenile myoclonic epilepsy, that respond very specifically to valproate. So we don't have to try multiple drugs to know the one that will work for a given population. We have improved enormously with our surgical techniques, and we now know that among the treatment-resistant patients, we can identify good surgical candidates and give them a very high likelihood of being seizure-free. Specifically, patients with mesial temporal sclerosis or mesial temporal lobe epilepsy should be referred very early for surgery because it's low risk and it has a very high yield. 2/3 of them will no longer have seizures after surgery. And our devices have also, although they haven't made people seizure-free, they have certainly improved quality of life. Vagus nerve stimulator, deep brain stimulator, responsive neurostimulator coming along the line will certainly improve seizure severity, reduce seizure frequency, improve quality of life. We would like to identify risk factors for epilepsy, such as genetic predispositions and other clinical characteristics that will allow us to treat with anti-epileptogenic therapies before people even have their first seizure. We do that with stroke. There's no reason we can't do that with epilepsy. We also need to take the patients who are treatment resistant and be able to determine their genetics and their patient characteristics that will allow us to target very specific therapies to each patient individually. And today we treat epilepsy, but we have a hope that tomorrow we can cure epilepsy, that we can intervene with therapies such as anti-inflammatory agents and other agents that will turn the brain from an epileptic state back to its more normal state.
Note that the definitive landmark paper on ethosuximide for absence seizures will be presented by Tracy Glauser this afternoon in the Hot Topics plenary session. Finally, for my last major disease example, we're privileged to hear Ralph Sacco, president of the American Heart Association, the first neurologist to serve in that position. When I mentioned T3 translational research at the start of my talk, I was thinking about a point Ralph will make. Dr. Sacco spoke to me shortly before his presidential address, the American Heart Association meeting in Chicago, first on acute treatment and then on prevention of stroke.
For acute stroke treatment in 2011. Almost 80% of the U.S. population lives now within 60 minutes of a primary stroke center. And the AAN and the AHA and the ASA have worked together to improve the number of primary stroke centers out there. Telehealth has also now grown up to improve access to acute stroke expertise. Acute stroke therapy requires a coordinated, multidisciplinary team effort. Vascular neurologists now are often at the helm, but we need to work together in teams to really address acute stroke care. IVTPA within 4.5 hours now is available and a very effective treatment, and it's even better if started sooner. Stroke centers, one of the key performance metrics is IV TPA use and trying to give it very quickly to really improve the outcome of a stroke patient. Comprehensive stroke centers also now have been born, and there you can perform recanalization therapies up to 8 hours after stroke. Not everybody will get better with IV TPA, and you may need rescue therapy. Some people come in longer than that 4.5 hours and need more interventional approaches, sort of like what cardiology does with acute MI. In our comprehensive stroke centers, we have more available to open up those blood vessels. In those that come in beyond those time windows, aspirin is an effective therapy within the first 48 hours of stroke. As neurologists, we need to be even more focused on prevention or brain health. Primary prevention of stroke is front and center for the American Academy of Neurology and for the American Heart Association. Their new campaign on ideal cardiovascular and brain health includes Life Simple 7. 7 key steps to trying to prevent heart disease and stroke. Never smoking or quitting more than 1 year ago, having a body mass index less than 25, being physically active, at least 150 minutes of moderate or 75 minutes of vigorous physical activity each week, a diet, 4 to 5 key components of a healthy diet consistent with our current AHA guidelines, having a cholesterol less than 200, having a blood pressure below 120/80, and having a fasting blood glucose less than 100. These are part of what's is called Life Simple 7. Right now in the United States, less than 0.5% of people meet all 7 of these criteria. If we can get more people, as neurologists, thinking about Life Simple 7, we will prevent stroke. One of the most feared complications or outcomes in a TIA or stroke survivor is having another stroke. Another stroke will cause so much more disability. So as neurologists on the front line, when we're trying to prevent another stroke, we need to be thinking about aggressive risk factor control like antihypertensives, statins, and glucose control in those that are diabetic or may have insulin resistance. We need to be thinking about carotid endarterectomy or angioplasty and stenting, which can be done to open up those that have symptomatic carotid disease. And here the subjective criteria become involved in picking between which is better, depending on age and other comorbidities. Warfarin is indicated for cardiac embolism and atrial fibrillation, but yet still underutilized. And there are new therapies coming down the pike. A new direct thrombin inhibitor now has been approved, and other ones are coming soon. Aspirin, extended-release dipyridamole and aspirin, and clopidogrel are all effective options to prevent a second stroke after a non-cardioembolic stroke. So what does the future for stroke therapy hold? Well, I hope that if we all practice Life Simple 7, that stroke incidence rates will decline due to a population shift to more ideal vascular health. However, because of an aging society, more strokes will be occurring, and there will be a larger number of stroke centers and a greater need for vascular neurologists. I hope neuroprotective drugs will be approved, and they'll be most effective if administered in the ambulance. And maybe even that ambulance will have a portable brain scan, and there's even prototypes of that available now. And then recanalization therapy will be done to open those blood vessels at the stroke center, maybe even with MRI-directed robotic devices that have less risk. And then the future of genetic testing. We hope that genetic testing will allow us to identify pharmacogenomic profiles for post-stroke antithrombotic, anti-inflammatory, and regenerative treatments. And maybe even stem cells will have a role. I hope we'll see some of these predictions come true very soon.
When Ralph told me about this, just as he's told you, I didn't realize that this would become a main point of this talk. But if 199 people out of 200 aren't doing what we know prevents stroke, and if all physicians, including us as neurologists, aren't figuring out how to change that, but are hypnotized by spectacular neuroscience, we may be making progress, but we aren't making all the progress we should. We see hundreds of patients who are worried about having a stroke, and hundreds of patients who've had a stroke themselves or had a family member or friend with a stroke. Riding the crest of this teachable moment, when a patient has a stroke, not only they but their family and friends will be susceptible to getting the message. This is obvious. But there are many ways to change behaviors. Neurologists have only just begun to do the research needed to figure out the best ways to accomplish this. T3, changing patient and physician behavior, has to move to the top of our agenda in order for us to bring the benefits of what we've worked hard to learn to all our patients. But there are other challenges to consider. Here I list 4 of the biggest. First, the fact that many of the at least 7,000 rare diseases are neurological, hundreds, probably thousands of diseases. Second, recruitment of patients for studies, of young people to enter our field, and of neurologists to participate in trials. Thirdly, the funding of the research. And finally, getting treatments to market, which involves the FDA. I'm going to consider each of these briefly. First, I asked one of Rochester's former trainees in our department's fellowship program for the experimental therapeutics of neurologic disease about her work on one disease. And after her, you'll see 2 of her patients' father, and then her patients, his 2 sons, Dr. Erica Augustine.
Batten disease is a rare lysosomal storage disorder with a prevalence of approximately 1 in 100,000 worldwide. As this family will show, children with Batten disease have a number of progressive neurologic impairments. Unfortunately, there are no disease-modifying therapies available, and premature death occurs in the 2nd or 3rd decade of life. Both Ben and John have a diagnosis of Batten disease, or of JNCL.
Right.
Tell me a little bit about how their symptoms started and when you first became concerned that there was an issue.
Well, I always thought John was a little bit quirky. Didn't see anything that we'd say, well, there's something really wrong, but we always just thought something strange. Now, maybe that was just us and maybe it's just coincidence, but even from the time he was young, but we didn't see any definitive signs or symptoms until he was 7 years old and going into first grade. And I was playing ball with him in the front yard, and I started throwing the ball to him, and it would just like go right by him. And I said, he's either terribly uncoordinated or there's something wrong with the sight. And the sight thing was it. We thought, ooh, he's not finding the ball. And so we took him to the eye doctor, who said, yeah, but his retinas don't look good. So we took him to the ophthalmologist, who said, yeah, the retinas don't look good. I don't know which came first. And then she said, he needs to be tested. So we went to the geneticist and got the diagnosis of Batten disease.
John, what kind of things do you like to do? I hear you like baseball.
Yeah.
Yeah?
Yeah.
Can you tell me about that?
I played baseball. Play baseball.
You play baseball?
Yeah.
And who's your favorite team?
Dodgers.
And what kind of things do you like to do?
In sports? I like football. I want to do football. I like hockey. I like golf. I'm going to pro golfer.
There is evidence that there may be a neuroimmune component to this disorder, as both children with Batten disease and CLN3 knockout mice both demonstrate autoimmunity. In knockout mice who are either immunodeficient or immunosuppressed, there appears to be a slowing of disease progression, particularly as it relates to motor features. Thus, in our first phase 2 trial in this disorder, we plan to pursue a means of immunosuppression as the primary investigation.
Here's Dr. Augustine's trial in Batten disease, just starting to enroll. But it's an example of that will need to occur hundreds and hundreds of times in the years ahead in rare diseases. And now the patient's father will tell you about their helping with the research. It is patients and families like this that inspire me and many neurologists in training to work on new treatments for rare neurological diseases.
We have to, as much for my wife and I as for our kids, is just do whatever it is we can to feel like there's some hope. Even if it's far-fetched or not very promising, we need to feel like we're doing everything we can to stay involved to, if it's not only helping our kids, which I think it is, just the input you get from, making small changes in medications, which just coming here today, we've gotten great insight into, some directions we want to take. But I think more than anything is to provide that sense of hope, too, for our kids, is to say, hey, these people here, meet them, talk to them. They care. They're working really hard every day, and they pray for the doctors every night. And so it's as much emotional as it is, physical.
It's families and patients that compel us to work on their disease. And the NIH is working hard to foster these research efforts. Through the Office of Rare Disease Research, there are now 19 rare disease consortia, almost half of them run by neurologists, including CINCH, our consortium on neurological channelopathies. We study 16 diseases, while the network overall addresses over 200 diseases. Rare disease research is progressing at the federal, state, and rapidly at the international level. For example, we have centers in 4 countries and now have a professor from China who's been working with me for the past 2 years before heading back to China to establish a channelopathy center there. A paper by my co-principal investigator on CINCH, Dr. Richard Barron, for our CINCH Channelopathy Consortium, will report a major, highly successful treatment later this week. The Office of Rare Disease Research has championed the cause, developing new programs for rare disease research. Now, Stephen Groft, Director of the Office of Rare Disease Research.
The Office of Rare Diseases Research has responsibility for developing the research agenda for nearly 7,000 rare diseases, many of which are neurologic in origin. We do this with partnerships established with the research community, the patient advocacy groups, and the industry. The NIH director, Dr. Francis Collins, has a very high interest in rare diseases research, both in his personal research experience with looking at diseases such as cystic fibrosis, chordoma, and progeria. Recently, he has established 2 programs to address many of the development needs of products for rare diseases by establishing the Therapeutics for Rare and Neglected Diseases program and the Cures Acceleration Network program here at the National Institutes of Health.
Next, neurologist Petra Kaufman, who was recruited to the NINDS to foster clinical research. Petra has highlighted the problem of recruitment into neurological clinical trials and is taking steps to improve the situation. First, the problem.
New treatments need to be tested in clinical trials. The problem is clinical trials take too long. In cardiovascular disease, for example, it takes on average 5 years to complete a trial. In neurology, 2 years longer. While there are many potential factors contributing to this, there's one that we can do something about, and that's patient enrollment. We at the National Institute of Neurological Disorders and Stroke are working on this issue, as are many investigators who are conducting neurology clinical trials. It can be done. What do neurologists need to do? They need to be trial investigators, and if they are, they need to design trials that matter to patients and to their colleagues, and that are not too burdensome so that people can actually participate. Neurologists need to educate their trainees about clinical research, and they need to tell their patients about trial opportunities and tell them why trials matter. And finally, it is upon all of us to educate the public on the need for clinical trials.
Since Dr. Kaufman's interview was taped, NINDS has made 2 interesting moves. They've added new specialists in recruitment for clinical trials, and recently the NINDS received applications for a new program that represents a sea change in the experimental therapeutics of neurological diseases. This program, which I expect Walter Koroshetz will consider at today's Hot Topics plenary session this afternoon, is called NEXT, the Network of Excellence for Clinical Trials being created by the NINDS. The intention is to improve the efficiency of neurological clinical trials through a partnership between NINDS, the Data Coordination Center, a clinical coordination center, and 25 clinical trial sites who involve entire communities in clinical trials. One example is the long overdue step of having one IRB, one ethics committee approval for all sites. This will be a major improvement in getting neurological trials up and running quickly. I'm sure we'll see new strategies for improving recruitment into clinical trials as part of this initiative. There are many steps to be taken to help get patients into clinical trials. Here's another one, presented by a former Rochester Experimental Therapeutics Fellow who was subsequently supported by an award from your Academy's Foundation, a growing program of fellowships initiated by Susan Spencer a number of years ago and championed by Foundation Chair Austin Sumner, by Daryl DeVivo, and by past President Fran Kittredge.
I recently came to help direct a movement disorder division and to build a telemedicine program for the Department of Neurology. Telemedicine, by removing geographic barriers, can change the way the care is delivered today and change the way research is conducted in the future. Currently, the access individuals have to neurologists is chiefly dependent on where they live. If they live in a major urban environment like Los Angeles, Chicago, or New York, they have ready access to neurologists and neurologist specialists. But if they don't, they have limited access. By using web-based video conferencing technology like Skype, which grandmothers use to communicate with their grandchildren, neurologists can now provide care to individuals with neurological disorders, whether it's Parkinson's disease or Alzheimer's disease, in the comfort of their own home. In the future, the same technology could be used to enhance participation of individuals in clinical trials. For Alzheimer's disease, individuals, it's hard to come to a research center. Now those same assessments that are done in part of clinical trials, many of those can be done in their home. For individuals with rare conditions like Batten's disease, researchers can now follow large cohorts of individuals with these rare conditions in the comfort of their home without subjecting the families to the cost and the burden of travel.
Another innovative way of helping patients to participate in clinical research. Next, I want to have one of our leaders look at the issue of recruiting the young into our field. Can we continue to recruit the best and brightest to fill the pipeline with the superstar clinical scientists to do the T1, T3, and I hope T3 work? Here's Stephen Galletta's perspective.
There's no greater time to enter the field of neurology. We've had a rapid expansion of the number of U.S. grads entering neurology, and with good reason. We have enormous research opportunities to take novel therapeutics from the bench to the bedside. Furthermore, we've seen a large development of our subspecialties driven by the explosion of therapeutics in a variety of disorders such as multiple sclerosis, Parkinson's disease, and epilepsy. We've seen a rapid expansion of the number of U.S. medical grads entering the field of neurology, over doubling in the past 15 years. Likewise, we've seen a rapid number of increased attention to the science of neurology, as over 50% of the MD, PhD work is currently related to neuroscience. Now, we are taking on a new horizon as we travel internationally to develop the skills of the neurologists who will bring new therapies across the world and provide the opportunity for patients that otherwise wouldn't have neurologic care to experience the top-level care that they can get throughout the United States and more developed countries.
I think you can see why Steve Galletta has managed to recruit at least one of our best Rochester medical students into Penn's program every year, including this year. Next, funding the research. The excitement of great new discoveries is now meeting the reality of the economic downturn and a flat NIH budget, or even a drop. There are also issues with pharma and with the FDA. NINDS has always been heavily involved supporting the Academy and research funding for neurologists. First, Story Landis, and then Walter Koroshetz.
The mission of the Institute is to reduce the burden of neurological diseases, many common neurological diseases and countless rare diseases. To accomplish this mission, we support research across the entire spectrum, from very basic studies to phase 3 clinical trials. We recognized, however, that we also needed to focus our efforts on harnessing our basic science discoveries to the development of treatments, and have created a translational program which takes promising opportunities from preclinical studies to an IND or an IDE. We also know that there is going to be an explosion of opportunities in the future, in the near future, to test these new therapeutics in patients. And that requires us to develop a very robust phase 1 and phase 2 clinical trial program to screen therapeutics before we take them into large phase 3 clinical trials. But a critical component of fulfilling our mission is the engagement of the neurology community in helping us to conduct those trials, and also in implementing the evidence-based medicine that results from those trials.
The NIH is a steward for the taxpayers' investment in biomedical research. And I'd like to leave you with a couple of very important take-home points with regard to that investment. First, little known, neuroscience research at $5.3 billion a year is second only to cancer at $5.6 billion a year. Second, the NIH research portfolio is very complementary and not at all redundant with what occurs in industry. Important to note, basic science research, which is the foundation for all of the scientific discoveries that could be translated into therapies or diagnostics, that basic science research is done primarily through NIH funding. If NIH does not fund it, it does not happen, and this has profound effects on the pipeline, both on the NIH side and the industry side. Working together, patients, doctors, industry, lay organizations, I can see a clear path for breakthrough therapies for many of our most tragic disorders.
While I've been president, this morning President's Award recipient, Jim Burnett, worked with the Academy to develop a conflict of interest policy. This focuses on monies pharma gives the AAN. This concern about pharma support of CME is often confused with the collaborations between neurologists and industry in research. Our first experimental therapeutics fellow, Carl Kieberts, now comments first on industry funding and then in a second video clip on changes at the FDA.
So I think recently there is a tendency to demonize a very fruitful relationship. That is, the relationship between academic investigators and industry. And by demonize, I mean that people who engage in collaboration with industry, whose primary jobs are in the academic health centers, are suspect as being improper. Their relationship with industry is made public. They have to disclose this. There's a connotation that there is something intrinsically wrong with that. Public commentators like Marcia Angel and others have really criticized the influence of the pharmaceutical industry on prescribing physicians, and that is not differentiated from the important collaboration between industry and academic researchers. There are concerns about abuses, but to demonize, to criticize the entire relationship is to lose our greatest potential for developing new treatments, which is a collaboration between academically minded, scientifically oriented physicians and researchers and the pharmaceutical and biotechnology industry. Those two things, that relationship should be celebrated, not demonized. Well, I think the FDA is taking an increasingly active role in trying to move potential interventions to being new therapies. There's a program about centers of excellence in regulatory science. There's the Critical Path Initiative. There is increasing motivation and activity on the part of the FDA to speed therapeutic development process. That is, I would say, different than a decade ago. Janet Woodcock and other people at the FDA have really driven that interest.
This new focus on centers of regulatory science at the FDA resulted in my longtime Rochester colleague, Ira Schulson, moving to establish such a center at Georgetown University. And Rochester's training program in experimental therapeutics views this as a great opportunity for training our young people. Ira will be talking at the Contemporary Clinical Issues and Case Studies plenary session later this week. Before concluding, I want to note some of the opportunities appearing while I've been your president. Clinical research and fellowship training supported by the Academy's foundation. 30 fellows currently supported, with a target of funding 15 new fellows every year. Your Academy's foundation, under Austin Sumner, has worked with patient advocacy groups and many subspecialties to support clinical research training. And I hope soon collaboration with the American Neurological Association and the Association of University Professors of Neurology. In fact, while Tim Pedley was the president of the ANA, we began discussions about collaborations in many areas. These discussions continue with current ANA President Bob McDonald, and I'm optimistic they'll go forward with ANA President-elect Eva Feldman, who speaks now.
So the American Academy of Neurology and the American Neurologic Association share the same vision, and that is excellence in neurology throughout the world, but particularly in the United States. Members of the Academy are practicing and academic neurologists, and when those members of the Academy partner with members of the ANA, the home of the academic neurologists, together we're going to be able to realize this vision. And we're already taking steps towards this realization. The Academy and the ANA together are jointly conducting an ethics committee, which is active. We also have plans together to merge our education committees so we can provide good mentoring courses and paradigms for neurology residents, fellows, and for our junior faculty. And we at the ANA hope to join with the Academy in supporting the very important scholarships and fellowships that the Academy currently funds. I strongly feel that by working together collaboratively, we're going to reach our shared mission, excellence in neurology in the United States and in the world.
There's more the Academy can do. We can support federal research funding, and this is something our advocacy programs support, really important now. We can support and work with other NIH institutes, and this is a new initiative we're making. 30% of neurological research is supported by the NINDS, 70% by other institutes. NINDS has helped with this. A month ago, we met with the National Institute of Aging, NIDA, the NIMH, NICHD leadership to promote their interest as well as ours. Plus, we can develop and support mentoring programs such as those Eva Feldman referred to for residents and fellows. 3 days ago, Chris Weil led just such a program for AAN trainees and others. In conclusion, our patients are counting on us.
You know, I know there's no promise for anything or for a cure or anything. It's you know, small steps, but it's significant to know that there's something being done. Okay, they're looking at something. Again, even if this isn't going to save our kids, you know, it's going to make an impact on kids down the line. And so, you know, I don't know if exciting is the right word for us, because we're not excited about it. You know, we spend more time just trying to stay in the moment and enjoy the blessings that we have today, and our kids are blessings today.
The opportunities for the best and brightest are enticing.
There's never been a greater opportunity for those that are interested in the field of neurology to think about the various opportunities that could lie before them. Of course, they could be practitioners, and we need practitioners, but the opportunities lie in academic medicine, as teachers, researchers, and clinicians are needed to lead the next wave of neurologic therapies.
Young neurologists are training in experimental therapeutics. Over 50 in Rochester in the past 20 years.
I'm interested in experimental therapeutics because although I'm interested in mechanisms of disease, disease, I really wanted to find new ways to treat patients. In Batten disease, we have a great model of moving forward with rare diseases as we collaborate both with scientists, with families, and with foundations. Through these relationships, we've had the opportunity to establish a cohort of over 90 patients with Batten disease, over half of whom have interest in participating in clinical trials. In this disorder in particular, these relationships have put us in a prime position to move forward in experimental therapeutics.
Partnerships with others and subspecialties are of the greatest importance.
As the first neurologist to be president of the American Heart Association, stroke was obviously critical to me. And what better way than bringing two great organizations, the AHA and the American Stroke Association and the American Academy of Neurology together, bringing the best and brightest of our membership together, working on one of the biggest threats to our health. Stroke is the third leading cause of death, an even bigger cause of disability, and I think only through collaboration will we make a difference in stroke prevention and treatment.
So I'm optimistic about the future, in part because I've been your president for the past 2 years and have seen the talents of our almost 24,000 members and our extraordinary Academy staff. Smart neurologist leaders are working on overcoming the obstacles. We have clearly made great progress and are poised to make even more. We have good treatments for MS, Parkinson's disease, epilepsy, stroke, headache, neuromuscular diseases, and many other neurological diseases. Optimistic neurologists can recruit the young. Many programs are flooded with top applicants. It can be done. Finally, for the sake of our patients, and we need to take what we know and give up some of our rugged individualism to do the research and get the answers on how to persuade patients and to prevent disease, develop systems to standardize care that should be standardized, and reassure patients that we're totally focused on them and their health. The list of people I should thank is so long it would take another 45 minutes to give. I thank my friends who spoke to you, the American Academy of Neurology staff who I've worked with. They're terrific. The Muscle Study Group collaborators I've worked with over the past 2 decades. Cinch Consortium investigators, especially Rick Barron, who's my co-PI. I want to thank my colleagues at the University of Rochester, especially my assistant, Pat Hopkins. And I want to thank especially my wife, Rosalind. Thank you very much. I now want to recognize the outgoing board members who have served the Academy in many ways for the past 4 years. Could they rise, please? It is now my pleasure to introduce to you the new board members elected at Monday's business meeting. Join with me in welcoming them. Being president of the AAN for the past 2 years has been a wonderful experience. I knew over 1,000 neurologists when I started, and I now know over 3,000. One of the rewarding aspects of my job was working with then-President Steve Sergey while I was president-elect. It was equally rewarding to work with your next president while he's been president-elect. Bruce Sigsbee and I immediately became a team and close friends, and I've enjoyed our work together immensely. Bruce calls himself a general neurologist and truly shares the concern of the practicing neurologist. At the same time, he runs a stroke center and handles challenging patients with MS, neuromuscular disease, in fact, all of neurology. Pay attention to his paper in Neurology published a month ago about the survival of practicing neurologists. Bruce has been a leader in the AAN for over 2 decades, with just a few of his many positions and contributions on this slide. It is my pleasure now to pass the gavel to Dr. Bruce Sigsbee, the next president of the American Academy of Neurology.
I wanted to say a few words about my friend Dr. Griggs. He has been a fantastic leader for this organization in many ways. He has indefatigable energy, as we all know, but also great skill at leadership, and he leaves your academy in great shape. Many people have told me that he's a hard act to follow. That's not really truly correct. He's an impossible act to follow, and I really want to extend all the respect and recognition to the job that he's done. Thank you.